gosh. I think we were recording before. Okay, we're going to talk about Intertrigo now. And basically, I just want to start by saying a couple of things. Intertrigo talks about rashes involving the intertriginous areas. The most common ones affect the groin. The other ones can affect the armpits, the antecubital fossa, and the popliteal fossa. And it occurs in any area where there's folds. You can also think about Intertrigo as involving the inframammary area in people with pendulous wrists, for instance, you know. And we do get patients just like that, and when you see that, you're going to sign them out as having Intertrigo. Now, when the same thing happens around the oral commissure, that means the corners of the mouth going down. It's a form in your mind, think of it as Intertrigo, but it's called Perlech. P-E-R-L-E-C-H. My spelling's atrocious, don't hang your hats on it. But that one in particular, and I'm going to just say something quickly because you guys have to know, you're going to see patients that come in and they'll tell you the rash going down, well, usually one side of their mouth. Now, what happens as you age, your mandible, your jaw recedes, okay? So when your jaw recedes, when you tend to sleep, the saliva, even microscopically, drips down between your lips. When the saliva drips down, what do we have in our mouth candida? Everybody's got a candida, that's a normal floor of the mouth. It gets on the skin. When it gets on the skin, it doesn't behave normal anymore because it's where it's supposed to be. So you got to treat it for candida along with the irritation that causes it. And again, you can tell the patients that even though you're cured, more than likely that's where you got it from, and it may come back. Don't get upset about it. When it comes back, use the creams, but you got to teach them how to use it so they don't get atrophy if you can use a topical steroid along with an antifungal. Yeah.
Which one would you put on first?
Well, you know, you could probably tell the patient to take a little drop of each one and mix them with the fingers and then apply it to the skin.
We had a lady
Okay.
yesterday. We had a lady with that on Friday.
And how did it treat him?
We gave her oxystatin, we had already given her steroid cream. But it was followed down and in her wrinkles down like that, and he told her she probably got it at night from.
Yeah, sometimes it's like really tough because you treat them and the saliva dripping down just adds to the same problem. You know, so. But just think of that, that's kind of an Intertrigo because you got one fold against the other. That's how it happens. Your cheek folds over your chin. It usually occurs in older people. How old was this lady?
She was in her late 70s.
Late 70s. She had a recession of her mandible, plus also rhytids, probably lying against one another. So think it's Perlech with Intertrigo. Same thing underneath the breast. When they're pendulous, you get moisture. It starts usually with moisture. So Intertrigo is equivalent to moisturization of those folds. All right. So now with that, if you press it and Ron, take it away.
All right, we start with Intertrigo. The path is basically its factors, secondary factors of inflammation and erosion. It's inflammation of the skin folds. It's moist. It becomes emaciated. Friction, and there's lack of circulation, which starts everything off. The frequency is complications. Basically, it's complications of diabetes, diaper dermatitis, and obesity. There's no difference in race, sex. It occurs in the very old and the very young. It presents as basically erythema. It becomes crusted, emaciated, fissuring, and then erosions occur in the skin folds. Differential acanthosis nigricans, Bones disease, candidiasis, allergic contact dermatitis, irritant contact dermatitis, granulomatous, seborrheic derm, scabies, syphilis. Basically, you do a KOH to make sure that to rule out whether it's fungal in nature. If you think it's psoriasis, Bowman's, or Paget's disease, you need to do a biopsy to rule that, to basically exclude those. Treatment, basically, I put Alcortin in here because I've seen this, 6 cases of this working so far, basically in older population. It works very well, and it's microstatin.
What is it?
Alcortin.
But what's in it?
Antibacterial, antifungal, and
Steroid combination.
Antibacterial?
Right.
antifungal, and steroid.
And there's only
What's in it? You know?
It's these 3 things.
Okay, our corn has iodoquinol, which is, it's an equinolone family. It's, and it's got hydrocortisone, acetate, that's it? Okay, it's iodo is much like iodine, betadine. Think of it, iodine, betadine. So they took some, and I always tell you that betadine works very well on MRSA. MRSA infections, you don't have to go nuts on it, huh?
The antibacterial is the
Yeah, so- And it's got some hydrocortisone, which is a very mild anti-inflammatory, you know. So it's got iodoquin, and hydrocortisone. Correct?
right.
Very nice. Okay. Microstatin.
Microstatin and Desitin, ProShield. Basically, the Desitin and the ProShield, basically those are zinc oxide based with another, usually it's petroleum to basically put in the shield. Then there's Castellani's paint. Basically, if you've ever seen that, it's just, it looks like a red paint. It's a drying agent. Basically, it's
It's purple.
purple. I thought we read it was purple.
Yeah, I think it's purple, and it stains very badly too,
It's
you know?
basically it's phenol, water, alcohol, and acetone.
Well,
That's a
what about
combination. That's what
that?
basically
Phenol, water,
water, alcohol,
H2O,
right, and acetone. That's what Castellani's paint is.
alcohol, and what else? Alcohol and
acetone.
acetone?
The acetone.
No,
Yes.
what's in Desitin? It's a zinc oxide paste and
Right, and petroleum.
petroleum.
Yeah.
So what about ProShield? That's the same as Desitin?
Basically, it's another zinc oxide base petroleum. It's just different company. And then Protopic, 0.1% BID for 6 weeks.
Protopic. What's in there?
That's what's that? It's like that same cruise as Aladil. It's in that same.
Oh, yeah, it's an anti-inflammatory.
Right.
Yeah, Protopic.
Now, it's not on here, but Dr. Wu and Dr. They like to use this. They call it triple paste, and then they like to, after it's clear, and Zenzorba. That's what they like to use both of those.
What's the one that I talked to you about when we were doing pediatric dermatology? Is Lazarus, yeah, Lazarus. Put that in there. Lasar.
LASSAR apostrophe S.
Yeah, and what's in there? That's paste, Lazarus paste, right?
Without, it says without salicylic acid, or with
What?
Barrow solution 1 part.
So wait, it's which is Burroughs, what else?
The aluminum acetate. Yeah, that's
Solutions.
Anhydrous lanolin something.
Anhydrous lanolin, anhydrous rather than.
This would
Bullious.
be to go to the compounding pharmacy, or?
Well, you know what, probably. You could write out as Lazar's paste if they have it, then underneath it, say, one part, you gotta write down how much you want. So depending on that, you have to kind of just work out a mixture that you might like it. But it has more than just that, doesn't it?
Yeah, it has some salicylic acid, 3 parts.
Salicylic acid. Salicylic acid, so it's 3 parts. It's good on kids, it
How
really
much
works
of
well
the
on kids.
anhydrous lanolin is in there?
2 parts. And you dispense on 800 grams applied at diaper area.
What else is that? That's it?
That's all I'm saying.
Bars and hydrous lanolin and salicylic acid. Yeah, that works good in kids with Intertrigo. Now the thing that, okay, what do we see most of the time? Okay, in adults we usually see, in adults we usually see Tinea cruris. And you really need to do good KOH so you don't miss it, because if you get someone on top of steroid, you gotta see them back in the groin, otherwise you're gonna get stretch marks. And when you see them back, it's worse, you know you got a fungus. Just go scrape it again. If you give them steroid, initially gets better with steroids. Even a fungus infection, initially it'll look better, and the patient will say, yeah, it's gotten better. But if it comes back and says it got better in the beginning, now it's worse, then you got a fungus. Scrape them again and use an antifungal, okay? And then it's very, very rare to see candidiasis in an adult. You usually get candidiasis only in adults with immunosuppression, and they have to be major immunosuppressed. Candidiasis usually only occurs in kids and infants. So, just be aware that you'll see satellite lesions. Let me see this picture on the other screen shows that. Let's see if we can see some. I'm sure there's a little bit of, like, you see these satellite lesions over there? I don't know if you can see them there.
Satellite lesions?
Yeah, I mean, I can't make it any larger right now. And this is something totally different. You guys have seen that, but I'm sure you're not going to remember right now. I don't want to get into it. Okay, so that takes care of Intertrigo. Okay?
Many times patients do come in with a rash on the shaft, which I was seeing somebody else's patient who came in for a follow-up for
Okay, the rashes, the penile rashes. Once you write down differentials that you think that you need to think about, okay? First write down a circumcised and uncircumcised penis. In an uncircumcised penis, you usually don't get infections because you're not captured by moisture, okay? That's one of the reasons that people get circumcised, and that's why it was a Jewish tradition really in the beginning about preventing that kind of thing. So in someone who's not circumcised, there's a great chance of getting things like candidiasis, but you're not going to see it in non-circumcised, in a circumcised person. Okay, then the other things that you commonly see in the penis are scabies, right? Lichen planus. These usually involve the head of the penis. Lichen planus, psoriasis. Okay, there's something like it's a thing, same thing as lichen sclerosis atropicus. Usually involves the head of the penis, but it has a different name in a male. It's called another abbreviation, I forget what it stands for. It's, it'll come to me, I'll tell you, but it's like LSNA. Then you've got something called zones balanitis, Z-O-O-N, apostrophe S. It's also known as balanitis plasma cellularis. It's basically an inflammatory condition like eczema, but on a biopsy you see a lot of plasma cells there. He usually responds to steroid treatments though, to like topical steroids. But you gotta watch what you put on the shaft because you could really, it's kind of mucosal membrane type of thing, so you're gonna thin out the membrane. So you can use much less potent steroids for a short time and get a lot out of it. Okay, so those are the most common rashes besides like herpes simplex, for instance. Another one is molluscum contagioso. We see a lot of that. So those are the common rashes that you see on the genitalia.
Is that guy, he had circumcised, and then he had been seeing Dr. Safe for a long time, and I think she was treating him with triamcinolone and then oxystat. She also gave him pills, corticosteroid and stuff like that. I think that he kept for about a week or so. And she had asked to follow up with.
Well, did he have a rash? Did he look?
Yeah,
What did
it
it
went,
look like?
went away. When he came back for a follow to me, he said it went away, but it came back. And then he has this ongoing for a year.
What did it look like?
Like, it was just erythematous.
Okay, listen, a lot of guys have these psychological problems about their penises, okay? I'm telling you the truth, okay?
He's
right.
I'm right, because one of you, I think, it was Patty McTaggart, the short guy.
You saw him after her, yeah.
Oh,
I was
yeah.
there the day he came in and he was telling Patty all these things he thought it was.
Okay, anyways, this guy was convinced his penis was going to fall off because he had unsafe sex with some girl. Anyways, Patty saw him, and the gentleman had what she said, probably Fox fordyces, which is sebaceous hyperplasia, and pearly penile papules. You've read about that, right? Little tiny papules that go around the corona of the penis. They look like little tiny papules. When I came to see him, the guy gave me nothing but a hard time because he was totally paranoid.
He thinks his wife gave him something she was cheating on, that's what he told Patty.
So you see, he's got the psychological issue. So what did I do? How did I deal with this individual? Okay? Nothing I could tell him was going to be right. It didn't matter what I said to him. He was convinced his penis was going to fall off, he was diseased for life. He thought he either had warts or herpes simplex or something. When I looked at it, he had almost nothing. He looked like what Patty said, it was probably right. So what's a smart man like me doing in a situation like this? Resort to a biopsy. So I said, sir, I'm not going to sit here and guess, but really what I was thinking of, it doesn't matter what I tell you, you're not going to believe me anyways.
Right.
So I'm going to need a couple of samples of the skin to see what you have. That guy just hopped on that table, like, go for it, buddy. He wanted to know right away. No big deal. I saw my nurses in, we joked about it a little bit. I got 2 biopsies, they're probably going to show us zilch. But you know what? He's going to leave. He's going to say, whoa, you know what? That guy knows what he's doing. No one suggested doing that. But I know I couldn't convince him.
What did Patty say to her? Should I read it?
Yeah, she said he had Fox fordyce, or Fox, it really isn't that, but what he was looking at, I thought was accentuated follicles around his penis, which he said he never had before. Well, how about if I said to him, sir, you didn't pay attention to your dick until you thought it was going to fall off because you feel guilty about something. How about that? Okay? So I think he had nothing but accentuated follicles. It's very common, every guy, but he wasn't paying attention until he got nervous about something. So, and then pearly penile papules. The papules around the head, between where the head of the penis and the shaft come together. Can you, Becky, write nail diseases on my list and genital diseases? These are future homework for Dr. Geffner. Okay? But if you see an email saying that I want you guys to get into it so that you can have some background and then I'll just talk about it, it's a good way of learning. So, I don't know, where are we going now?
Early penile.
Okay. Why did that come to be? What was the question here?
She asked.
Oh, you got medication. Okay, I'm
He was
sorry.
being treated like for, with.
Okay, so listen,
anti-fungus.
here's what you tell a patient like that. Sir, you've been treated for quite a while, and now we have to stop the medication and leave it alone. Don't worry, you probably have nothing, but we need to check you back in a month. I don't want you putting anything on it, okay? Please come back in a month. Give him a little break. See what happens, seriously, because you only see a little erythema. So forget it. Right now, just take a little break. Let's see what happens. You
So
go
it
from
was
there.
not only on the penis, but it was also on the scrotum area a little bit, so that's why, I don't know. I
So the
just had
erythema was-
follow-up, so-
But maybe any irritation from the medication he was using that got on the... let me tell you something about men. If your husbands, wives, or boyfriends haven't told you this, I'm going to give you some personal experience that go along the board just about it's everybody in this room. And there's two guys here, and you should be honest about this. It's very rare that a man's scrotum does not itch. I mean, I'm not saying it's rare. I'm saying it occurs off and on all the time. Okay? It does, because of the location it's at. It's a mild case of Intertrigo that's symptomatic without a rash. So if you see somebody coming in and saying he's itching down there, give him a little bit of steroid, topical steroid creams, tell him to use it for 2, 3, 4 days, not to use a bar soap and soak it, because they think they're unclean or something, and they'll be fine. Same thing when you got, another big area of Intertrigo is between the buttocks, perianal. Give him some triamcinolone buttocks, have to use it for 2, 3 days. Make sure you note it in your chart. Because if he keeps using it and he has untoward side effects, you want to cover yourself. Tell him to use topical steroids and it'll go for 2 or 3 days, it'll go away. Tell him that it's chronic, it'll come and go, not to worry about it. Okay? Now, if the perianal pruritus is very severe, you know what they say, you gotta look for parasitic infestation. Sometimes it's a sign of internal malignancy, whether it involves the rectum or a lymphoproliferative disorder, like lymphoma, or something of that nature. Okay? So that's what you deal with. But Intertrigo affects many different areas of the body. You can see, on the face, it affects the lips, called prelesh. The rest of the body is the folds that we talked about, inflammatory folds, groin, armpits. How many people see rashes in armpits? I've seen them from deodorants and this and that. Okay? And also, genital area and perianal. So you got a lot of areas it affects. It's a very common cause for people to come in for a treatment. But if you're going to give them someone on topical steroids, follow up on them. Give them a small amount, 15 grams, so they don't abuse it. And then tell them that they should check in with you because these cortisone creams can thin down the skin. Alright? Okay. So let's go through some other things. Well, you can hold on from yours because you did Pleva,
PRP and scabies.
PRP, and scabies. Becky, what'd you do?
Pemphiogoid, Bullious, Pemphiogoid, necrobitis lipoidica.
Oh, that's important.
Morphea.
What about Cynthia? What'd you do?
I did keratonic.
Oh, the ichthyosis.
Yeah.
Okay, we can wait for that because that's going to bum a lot of people out because you got to think about that stuff. What'd you do, Lauren?
Vitiligo and pyoderma gangrenosum and xanthomycin.
Can we go away, Kathy?
PCT for keratosis and
How we can wait? What about you, Mike?
Well, I don't have a PowerPoint or anything, but they told me right about some things here. Mongolian spots, strawberry mangioma, erythema nodosum, erythema chronica migrans, erythema angulari.
Significant. Yeah, I know, they're hard to pronounce. Yeah. All right, here's what we'll do. We're going to Well, I wanted to work, I think Becky's got some good stuff. And then next time, we gotta start with your stuff, and then go to the rest of the people. Because that's the order of importance I see here. Okay? Okay, so, Becky, let me go to your thing here. Hold on. Do we not save your stuff?
Really good. Well, I have my list.
Okay, now, let me do that again. As long as we're doing that, I want to make sure that got saved in Lisa's thing. Hold on. What happened? I didn't save it? Okay, let's put your thing in and see. Otherwise, what you'll do is you'll have to email it to me, okay?
What's your email address again?
My name at gmail.com. It's pretty easy to remember. Oh, I'm going to just change it a bit, okay? Because I can't see the wording here,
No,
okay?
I mean, I don't know why it's saved like that.
No, I got it that way too, and
Oh,
I changed that. I did edit, select all, and then slideshow. No, those, I didn't do that. I did, I'll edit. And let's see. It's now. It's not shown now. View. First, I'm going to do view. Where's the view?
normal, maybe just a normal.
No, I wanted to go to notes. Highlights. Oh, site design. That's what it was. Mhm. Well, it just goes on site design. Okay,
This is select all and the
there
data.
it goes. Okay. So let's just go to Pemphiogoid here. How many of you guys seen Pemphiogoid? Anybody?
Right.
No, but Lisa, when I was with her last week, I didn't see it, but she treated a guy for it. She put him on CellSat.
Oh, she did?
Yeah, but we were trying to get in contact with her.
But let me ask you, how's it going?
Platelets dropped from 150 to 81
She shouldn't be doing that stuff. Are you gonna be working with her soon?
tomorrow.
Can you tell to call me about that patient? She shouldn't be using CellSat because,
You have to
I don't want to get her in
level.
trouble.
Right,
I don't know what
right.
else she treated him with. She's been treating him for a while, so I don't know
Well, do me a favor, just, I'm gonna be doing biopsies tomorrow, so that's not good. Can you get the guy's name though? I wanna see if he was put on Cytoxan or Imuran before she did that.
I think she's been treating for a while, she said.
Yeah, if you just find out, I'll tell you what, find out if he was treated.
Huh?
Find out if he was treated with an
I'm
immunosuppressant.
saying, if I have a patient, I'm not treating, I'll send.
I was looking up something because I didn't remember what it was, that's why it just came to mind.
From working in.
I saw two cases.
Oh, yeah, you've seen it before, yeah.
No, listen, I don't want you guys using Sasa, okay?
No.
I mean, it's very untraditional to do that. I'm gonna show you how to do it. I'm gonna teach you how to treat people the right way. There's nobody that in 25 years I couldn't treat that had both Pemphiogoid with the stuff I used, and they did fine. Okay? So, let me talk about it again, just to give you the main points about it, okay? Number one you should know is that the difference between pemphigus and Bullious Pemphiogoid is that in Bullious Pemphiogoid, there's usually only about 20% involvement of the oral mucosa. In pemphigus, there's usually about 50% involvement of the oral mucosa. Pemphigus takes much longer to burn out as a disease in general than Bullious Pemphiogoid. Bullious Pemphiogoid usually burns out within 3 years, 3 to 4 at the most. It basically goes away. It's a high immune response to God only knows what sets it off. But Bullious Pemphiogoid is something that usually does go away and gets much better. Pemphigus, on the other hand, is very detrimental. There's a high, with that treatment, there used to be a very high mortality rate with it. Bullious Pemphiogoid is very uncomfortable. The mortality rate was not as high at all. And generally speaking, patients with pemphigus tend to be much younger than patients with Pemphiogoid. Okay, so you're going to see Bullious Pemphiogoid in patients in their 70s, 80s, and 90s. You're going to see the group of pemphigus, okay, usually much younger in life, 30s, 40s, 50s. Okay? So that's the idea. Okay? So that's the way we're going to start with. Now, you cannot tell the difference a lot of times between a lot of these blistering diseases. They talk about the facility or the tenseness of the bulli, which I have a real tough time deciphering. But I'm going to show you something interesting. You see this patient here? She has not only blisters of bulli, but she also has a lot of erythema around it. Okay? Now, a lot of times when Bullious Pemphiogoid patient starts, it looks like urticaria. If you don't see blisters, they look like they're coming in and they look like they have hives. But they're usually larger than normal hives, and they're somewhat itchy and bothersome. So sometimes when people do biopsies, you get a biopsy result back and it says the urticarial phase of Bullious Pemphiogoid, then that's what you're dealing with, just an antecedent before you start seeing blisters. Now when you start seeing patients like this, don't be shy. Call me out, call Patty out, call someone who you really have faith in, and we'll help you get through it. You can see what happens, the blister, when it pops, it forms an erosion. That's an erosion here. It's not an ulcer. An ulcer is something that's deep. When an ulcer is something that goes into, the subcutaneous fat and the dermis, the deep dermis, the reticular dermis. This is something that is in the superficial dermis, and it's called an erosion, not an ulcer. See, here's an erosion right here. That's the skin that came off the bulla. This is the bulla. There's different signs. The Kolsky sign. Don't worry about it. It's all very academic. I've never seen it happen. Maybe I'm not as good as the Bush section. Again, you see this erythematous basis with blisters on? The bullae right here. And this is someone who doesn't have a lot of bulli or vesicles, mostly erythematous patches and plaques. He's got a couple down here, you can see that, and one on the back. But that's kind of like where it's at. Here's an intra-oral blister. I have yet to see one, and I've seen quite a lot of Bullious Pemphiogoid. It doesn't happen that often. The Pemphigus it does. This is just close up of blisters. See this rat, this erythematous area? You can see just some tiny superficial dried up erosions. Erosions. Anytime you see an erosion, just don't think anything but there used to be a blister. That's the answer in your mind. There used to be a blister. If you see erosion, there used to be a blister. There used to be a bulli, a vesicle, because that's what they leave you. We won't get into the nitty-gritty pathogenesis for right this second. Look, it involves the mucosa. This is the vagina. You see the erythema. And I'm sure there's an erosion here. There's probably erosion there. And sometimes you just see it without it surrounding the erythema. A lot of times they'll have it surrounding the erythema, erosions in the legs. They're just different forms of it. If you see blisters, don't pop them unless it really bothers the patient. Because an intact blister is sterile, yeah.
Where would we do biopsies?
Punch the
Show us a
bull out.
picture
Don't
and-
you punch the bull out?
Okay, what you do is, this is hard to do, but I'll tell you what the books say. If you had let's pick out a body here. Let's say you're doing this. You're going to get two biopsies. One for an H&E and one for amnio, okay? And the H&E, just, you could divide it up, or the patient has so much involvement, I would just take one piece for each. So you give the pathologist, a good sample.
But
Okay.
where on
It looks like they biopsied these stitches down on the bottom
Well,
there.
here,
Right there.
yeah. Well, in here, if you only have one blister, which would be unusual, you could just do like a peri lesion or scan right here, lesion right there. Not in here, just outside at the edge, somewhere here. Okay, and you can take another one for amnio anywhere here. This would be for H&E, next to the blister, and you could go a little further out for an amnio. Okay, but most of the time we can tell by H&E, because you see a huge amount of eosinophils, huge amount. First you see neutrophils, then it changes into lymphocytic eosinophil kind of disease. This is just an bone in the umbilicus right here. Okay, now Becky, why don't you, I'm going to give you a microphone.
Something like that. Who's that?
Oh, how I hate to do this. Still recording. Okay.
Alright, so we're gonna start with Bullious Pemphiogoid.
A little closer to your mouth, please. Closer to your mouth.
It's an autoimmune subepidermal blistering disease, primarily affecting the elderly. The age of onset is like 60 to 80 years. No racial or gender prevalence. Etiology is basically interaction of the oral antibody with the Bullious Pemphiogoid antigen, which builds up these complement, which activates the complement system and the neutrophils and the eosinophils. The sites of predilection, axilla, medial aspect of the groin, flexor aspects of forearm, abdomen, lower legs, which is often the first manifestation. Mucous membranes, practically only in the mouth, like 10 to 35%, and less severe and painful in comparison to pemphigus. Facial involvement and
Okay, you know what, I wanna just do one thing. Since I can't move the camera too well, can I have a speak for a second? It's important with any blistering, with all these blistering disorders, is to really understand what the basement membrane looks like. So I want to try to explain this to you. Okay. Oh, actually, they have. Okay, this is the basement membrane, okay? The basement membrane is that area microscopically between the epidermal cells, which is in this location, and the dermis, which is right here. So you got the epidermis on one side and the dermis on the other side. The hemidesmosomes are attached to the lamina lucida, okay? Underneath which there are different collagen fibers and structures in the lamina densa. The lamina densa is attached to the dermis by these anchoring fibrils. So you got the hemidesmosomes holding the epidermis to the dermis through these hemidesmosomes, and attached to the dermis through the lamina densa and lucida through the anchoring fibrils and the plex. So when Becky was talking about what happens in post-pemphigoid is that there are antibodies, immunoglobulins attached to this structure right here that causes separation between the epidermis, the epidermal cell, because this is the cell membrane. So think of this as one cell attached to the underlying dermis with the hemidesmosomes, and then these attaching to the dermis. This is where the problem is, right in this location. Everything's trying out for me today. Okay, so that's it. You're going to see other blistering disorders where this is not affected, but rather other structures in the basement membrane are. Okay, so again, cell membrane is this thing around. This is cell. That's connected to the dermis. Through this area. Okay.
some of the trigger factors for the formation of the autoreactive antibody is usually unknown, but has been associated to some of the drugs like Lasix, captopril, penicillin, sulfasalazine, and alloprol. Also associated with other diseases like diabetes, rheumatoid arthritis, dermatomyositis, ulcerative colitis, and thiomyoma. Physical findings. It usually begins at a localized site and remains localized throughout the entire phase of the disease. And in some cases, it can get generalized. Usually begins as hives, pre-blistering rash with localized areas of erythema or with pruritic urticarial papules coalescing into plaques. So initially starts as the erythema, as Dr. Gaffner spoke about. They will form erosions, and from erosions they get to plaques, which turn deeper red in 1 to 3 weeks as vesicles and they rapidly appear on the surface. I have that line, I made it bold. That's a very important line. What it actually tells you is that the bullae are tense, which means firm pressure on the blister will not result in extension into a normal skin, and that kind of differentiates it from the Pemphiogoid bullous.
She's talking about this area right here.
So it's a very tense blister, bullae, which when you kind of put a firm pressure on, it's not going to get back to the normal skin.
Is that what they talk about in Nikolsky sign? Nikolsky. Do you hear it?
Nikolsky's when you actually put
When you push
pressure
it
in,
down,
you know.
And then there's an expansion, so it has a negative, you're saying,
So this is
it has
negative, yeah.
negative Nikolsky sign. You know what Nikolsky sign is then? Nikolsky, Nikolsky. It's called Nikolsky sign, is when you push on a bullae, which causes it to spread out, to cause the fluid to spread out.
So the bullae rupture within 1 week, leaving behind eroded base that does not spread but heals rapidly. And there was a picture, next slide. This is how it looks like.
Okay.
In terms of diagnosis, as we spoke about the biopsy sites, under the microscope it shows subepidermal bullae with an infiltrate of eosinophils within the dermis and blister cavity. Immunopathology, linear IgG deposits along the basement membrane zone are seen, and also C3, which may occur in the absence of IgG.
So in other words, where the Henry's desmosomes are that I showed you, is where they basically find these immunoreactants. It's on the upper part of the dermis and just below the cell membrane in the lamina lucida area.
When you get the blood test, you'll see the IgG antibodies are seen in 70% of the patients. Treatment. Localized variants may respond to topical steroids. Severe cases, an effective measure is pulse therapy with methylprednisone, which is like an infusion over a period of 30 to 60 minutes daily for 3 doses, followed by piopreznisone if necessary. This is only for severe cases though. In persistent cases, immunosuppression therapy is needed, and azathioprine is most commonly used. Low doses of methotrexate, 2.5 to 10 milligram weekly, is effective and safe in elderly. And then tetracycline and or nicotinamide has been reported to be effective in some of the cases.
Okay, what I really want to do is work on the treatments. See, all the stuff that I taught you before has to do with your maturation into treating more chronic conditions. So do you remember that we talked about the side effects of prednisone? And the reason this is going to come into effect is because now you could use it in treating this disorder. Can you hit Joe's computer there? The one closest to you? Okay. 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 Who remembers how we start when we do the prednisone? First of all, let me just say that the majority of patients that come in with both Pemphiogoid will not respond to only prednisone. They're going to need a prednisone-sparing drug. Prednisone-sparing drug. The prednisone-sparing drug, which is most commonly used, is Imiran. Now, Imiran is used in a lot of also cardiovascular diseases such as lupus and dermatomyositis, etc., etc. Okay, so actually when you see a patient, you're going to take your biopsy for H&E. The patient comes in, he's got blisters. Okay, you take your H&E and immuno. When you see a patient like that, you're not going to wait to treat him until he comes back the second time, right? Because you're going to assume he's got a mechanical disease. You're going to start him on prednisone. Okay? If he's real bad, start him on 80 milligrams. And if he's not so bad, you can start him on 60 milligrams. And these you don't take it like you do the acute contact dermatitis. These ones, it's probably going to be a prolonged thing because it's a condition that lasts for many years. But if it comes in and they're severe, you're already going to start thinking that when the biopsy comes back to confirm it, along with prednisone, listen, you're going to use Imiran. Okay. Do you know what the dose of Imiran is? Is it comes in 25 milligram pills or 50? 50, okay, that's right. Okay, the way I'd like you guys to do this is the following. You're going to initially start them with prednisone. They come back in 2 weeks, or probably 2 weeks, because you want to see how they're doing, okay? Maybe the biopsy will be back by then, and they have a lot of blisters, okay? Don't wait to see if you can clear with prednisone. You're probably not going to be able to. Just take it from someone who's been doing this for a long time with them. One of the things you can do on an initial biopsy, on an initial visit, you're also going to get a CBC and a CAM profile. The reason you're doing that is because when you start patients in Imiran, you got to check their CBC status to make sure there's no suppression of the bone marrow, and at the same time check their liver function test because that's where it gets metabolized. Now, I've not seen in the time that I've been doing this a lot of immunosuppression, but what I've seen was severe portal hypertension. Do you know what that is? Kathy, did you ever hear this?
I have heard of it, but I'm not sure of the path.
Do you know that? Does anybody know what portal hypertension is? That's okay.
Oh, yeah.
What?
Yeah, it's the,
Here's the liver. Here's the heart. Okay? Going into the heart, you've got the superior vena cava and the inferior vena cava. Okay? They come in and they drain into the right atrium, right? Okay. This blood comes from the body and the lower extremities. Everywhere, okay? Gets filtered through the liver, okay? And back into the heart. to go through his chambers into the lungs to get oxygenated and all that, okay? What Imuran causes is a stasis in this area, okay? And as a result of that, it puts a tremendous amount of load on the inferior vena cava. And what you end up seeing when this occurs, which is not good because mold metabolites can't get back into the system to get clean, oxygenated, and corrected. And what you see here is when you start taking your liver function tests, you start seeing an elevation of liver function tests. And I'm talking about they go into the hundreds and the thousands. And when it occurs, it usually occurs quickly and within the first few weeks. So whenever you put anybody on Imuran, I'd like to get almost weekly blood tests for the first 4 to 6 weeks. Okay, weekly blood test first 4 to 6 weeks, and thereafter you could do it every 2 weeks, and then maybe after 2 months you do it once every 3 weeks, and kind of taper your blood test because you're watching for 2 things: suppression of the bone marrow and an increase of liver function test. If you see that, you got to back off the Imuran right away. Okay, and also for the suppression of the marrow. Now let's assume you've done your blood test and everything is good, okay? And you make sure you see that patient, okay? Because you're going to be very friendly with that individual. You're going to see him a lot, okay? The next thing you do is you're going to start by putting him on Imuran 50. And remember, you're going to probably start doing that after the next follow-up. So you see him initially, you do your biopsies, get your blood tests, put on prednisone. Next time you see him, you're going to add some Imuran, you'll have your biopsy diagnosis back, and you know he's definitely got that. And then what you do is, on top of your blood test again, and you put him on 50 milligrams of Imuran. Okay? And you're going to leave him on that drug for 1 to 2 months. Why? Because all these, I call chemotherapeutics, immunomodulators, steroid-sparing drugs, take about at least 1 month to kick in. So the minute you give it to them, you count 30 to 60 days before they even start working. So that's your baseline. That's when they're going to start working. As you're watching this work, the prednisone that you start the patient on, you're going to very slowly continue tapering. Now you're going to do that together with me in the beginning until you learn how to do this well. But remember I told you you're going to go from like 80, maybe for 1 week, to like 60. You probably stay on 60 for a couple of weeks. You make sure you add your Tagamet, calcium, and a good history, okay? Adult onset diabetes mellitus, hypertension. I don't think you're going to need to worry about pregnancy at that age. And what was the third one? Ulcers we discussed. And what was on that to do with the last part of the list? I forgot. So you get your history, you keep on for 2 weeks. By then, you know that the patient has already started the Imuran. Okay? The Imuran was started. Then when you get down over the next, say, over the next 2 months, down to 20 milligrams of prednisone, you're going to start, did I say 2 months? 2 months here?
Yeah.
I'm assuming that you continue tapering this because the patient's going to do better. But if he starts finding out that as you taper, he's having a flare up, you go back to where you were before you tapered him. Okay? Now let's assume he's doing great. He's just still breaking out a little bit. You could potentially increase the Imiran to 75 milligrams or to 100 milligrams. You might have something to break the thought in half. You don't do that for about 2 months after you started in the mind. 2 months, so this would be the 3rd month. I'm always afraid of increasing Imiran too rapidly to cause all these side effects, okay? When you get to 20 milligrams of prednisone, remember what I taught you. 17.5, 20, 17.5, 20, then 15, 20. Okay? You want to decrease it in such a manner that you end up with giving him 20 milligrams every other day. Every other day. Okay? Every other day. Because that decreases all your side effects. Very, very good. You know, the fat from moving to different places, premature cataract, aseptic necrosis of the femoral head, etc., etc. We dealt with that whole chapter. You were here at that? Or no, you weren't? If you remind me when we go back to some basics, I could deal with that whole thought process. Okay? Because it took about half an hour. We just talked about one drug. So the bottom line is, you're getting him down prednisone, getting to every other day dose, and at the same time, you're watching him and you may have increased the Imiran. Now you're not going to do this, I'm sure, by yourselves, or ask them to help you, and I'll orient you. Here's the goal. What's the bullseye? The bullseye is that you get them all prednisone all together. You're keeping on the least amount of Imiran, and then you start taking the Imiran. So then in 3 or 4 years, when the disease is gone, he's also basically over Imiran. And that's the whole thought process. Would you have a question, Mike?
No.
So that's kind of like it. Prednisone and Imiran. Taper off the prednisone to eventually where you stop the prednisone altogether. You hit the patient's on Imiran, then you slowly get them on Imiran. That's the way we're going to deal with all these blistering diseases. Okay?
So how long could the patient stay on Imiran if they have the...
He could stay on it for 2 or 3 years before you know. Yeah, so the major drugs you should start reading about is Plaquenil. We talked about Plaquenil. A big one is called Dapsone, D-A-P-S-O-N. We use that a lot. We use Dapsone, and I forget where we use it. When we come up to that disease, you'll see it. Imiran and prednisone, those are your big fours. And then, of course, the Accutane. Lamisil. Those are the drugs you really need to be concerned with. Okay? I just go into Pemphiogoid because we're going to, after your thing, we're probably going to stop for today. Well, let me just move the camera a second. Okay.
pemphigus. It's a serious acute or chronic Bullious autoimmune disease of the skin and mucous membranes based on acantholysis, which basically is loss of normal cell-to-cell adhesion in epidermis. There are two major kinds of pemphigus.
Okay, let me just make a comment, not to interrupt again. But the thing about pemphigus is that what does acantholysis mean? When you hear the word acantholysis, it means separation. That's all. You know, in Pemphiogoid, you had antibodies attacking the area between the epidermis and the lamina lucida, the hemidesmosomes. In this condition, what you have is antibodies attacking the sides between the epidermal cells. Like over here. And so the separation, okay, between these epidermal cells, and where's the actual attack? What do they say it is, Becky?
It's the calcium that actually binds the two cells. The pemphigus actually forms an antibody which kind of works on it. That's what it is.
And well, what do they use, or what structure do they say?
Just an epidermis. Cell-to-cell adhesion in epidermis.
So right here between where these things are basically held together by, are they held together by any structures called desmosomes or anything?
No, they didn't say anything of that sort.
Okay, this is what happens, and so when you look at a biopsy, this would be normal. You'll see these cells like floating in a blister, separated. You see by fluid spaces. Let's put it this way. Remember in eczema, you get these things kind of stretching, and you get a little bit of fluid in between that, and you see some inflammation. In this, you actually have the entire collapse of their adhesions, and they separate. Okay. And depending on where the separation is, there's different forms of this condition.
So there are two major types of Pemphigus vulgaris and the Pemphigus bullious, and each of these have variants. And the third kind is the paraneoplastic pemphigus, which is associated with some kind of tumors. So Pemphigus vulgaris, it's rare, more commonly seen in Jewish and the people of Mediterranean descent. Age of onset is 40 to 60 years, and equal incidence in male and female. Etiology, as we spoke, it's an autoimmune disorder. It actually forms antibodies that separates the cell-to-cell adhesion, also known as acantholysis. And the two circulating autoantibodies seen in this kind, which is Pemphigus vulgaris, is the desmoglein 1 and 3. Now, the reason I really emphasized on this, because this differentiates one from the other. Clinical manifestations usually starts in the oral mucosa first, and next most commonly in the groin, scalp, face, neck, axilla, or genitals. The mouth lesions appear first in 60% of the cases, and months may elapse before actually the skin lesions occur. They could either be localized for months, after which they generalize to the other areas. Pemphiogoid, usually patients wouldn't complain of any pruritus in comparison to the ones in Bullious pemphigoid. They are painful and tender lesions which occur in the mouth secondary to the erosion and may prevent adequate food intake. Some of the other symptoms that are associated are epistasis, hoarseness, dysphagia, weakness, malaise, and weight loss.
If you concentrate on the picture on the other screen, what you'll see is that you see the erosions, they look like they're white in color, right there. So that's what it looks like. You're not going to see blisters, you're going to see erosions. And the erosions are very painful, and the problem is that they don't just stay in the mouth. They stay also, they go down the entire mucosa of the oral mucosa. So the patients who come in usually complain of having inability to eat and swallow, because it bothers them to swallow. And they usually end up losing weight, and they're not comfortable at all. They're usually in pain. This is again, what a patient with Pemphiogoid vulgaris looks like. You see, it looks like it's a lot worse, and it occurs anywhere in the body: the scalp, the face. There are different forms of pemphigus that we actually been talking about. Cicatricial pemphigus that involves just the eyes, just the mucosal membranes. In other words, the mucosa of the oral cavity, and or the nasal passage, and or the ocular mucosa. So there's some pemphigus forms that just are limited to the oral mucosa, the oral or the eye. These are just some. These are just some other examples of pemphigus vulgaris. Let's go through these for the next one. This is the scalp lesion, the body. You see, they look like they're more erosive than the post-pemphigoid. They look more superficial, but they tend to have a lot more erosions because it seems like they pop a lot quicker. Go ahead, I don't want to get into this one yet.
The skin lesions, they do start as bullae with serous content. They're very flaccid. This is another differentiation between Pemphigus vulgaris and the Bullious pemphigoid. The Bullious pemphigoid were very tense bullae. These are more flaccid. They easily rupture, that either appear on apparently normal skin and mucous membranes or on the erythemated space. So once the bullae ruptures and forms erosions, they are very painful and bleed easily. They soon become partially covered with crust that have little or no tendency to heal. Positive for Nikolsky sign is the sign I just spoke about, little pressure, the bullae are going to form erosions. In terms of diagnosis, the direct immunofluorescence is performed on 2 biopsies, one from the edge of a fresh lesion and a second from an adjacent normal area showing IgG and often complement C3 in the intracellular substance areas of the epidermis. And the other is the indirect immunofluorescence, which confirms the circulating serum IgG antibodies in 89% of the patients with the active disease. Treatment, usually piopernosone until cessation of new blisters, formations, and disappearance of the Nikolsky sign,
and then tapering it down afterwards.
Yeah, we don't need to talk about the treatment, we should just go on to the next form. Because it's basically the same thing, a immunosuppressive, like a steroid-sparing drug, like Imuran. Cytoxin is good too. I've used both of them, I like both of them. I think Cytoxin comes as 25 milligrams, is it? And I've used both and they both work well. I actually use Cytoxin in patients who are really, really bad. I usually use Imuran for those who are bad but not severely bad. And I can differentiate that seeing a patient. I've just learned to do that. Beck, you want to talk about the drug-induced pemphigus? I think that's important.
Yeah, it's one of the variants of Pemphigus vulgaris. Clinically, they're identical to the sporadic Pemphigus vulgaris. Several different drugs kind of implicated, and most significantly is the captopril and the penicillinamide.
That which is used mostly in, I don't know if they use it anymore, but in rheumatoid arthritis. So don't forget to ask the patients on, about their medication history.
The other variant of Pemphigus vulgaris is the Pemphigus vegetans. It's a mild variant of Pemphigus vulgaris. It's granulating vegetation, purulent plaques, vesicles at margin, usually confined to the intravenous regions, perioral area, neck, and the scalp. The entire course otherwise remains the same as vulgaris. The other kind is the Pemphigus foliaceus, which is relatively mild, chronic variety of pemphigus characterized by flaccid bullae and localized or generalized exfoliation. This one, the prevalence of Pemphigus foliaceus in Jewish heritage people is much less than in the Pemphigus vulgaris. And there is high incidence seen in young Tunisian females. This is also an autoimmune disorder, loss of cell-to-cell adhesion, ectapolysis, and the circulating antibody that we see in this one is the desmoglein 1 only. You do not see desmoglein 3 in this one. The skin lesions, they're most commonly seen on the face, scalp, upper chest, and abdomen. Scaly crusted erosions on an erythematous base. The oral lesions are rarely seen. Positive for the Nikolsky sign. First lesion is still the flaccid bullae that ruptures as they evolve to form crusting, below which is a moist surface with a tendency to bleed. Diagnosis with the same thing, direct immunofluorescence and indirect immunofluorescence. But the antibody we see in this one is just the desmoglein 1. Treatment options still remains the same with topical steroids, pioprednisone, immunosuppressants in severe cases.
Forget that. Forget the Brazilian essence.
Yeah, I'm going on to that.
Hold on. Just go right to paraneoplastic pemphigus. No, because I'm not going to see it. It's just academic.
Okay. The paraneoplastic pemphigus, patients with underlying neoplasms, most commonly the non-Hodgkin's lymphoma, the chronic lymphocytic lymphoma, Castleman's tumor, leukemia, sorry. Castleman's tumor and thymoma, who presents with painful mucosal ulcerations and polymorphous skin lesions, which progress to blistering eruptions on their trunk and extremities. Now, the mucosal lesions may appear lichenoid or more commonly Steven-Johnson's-like with crusting of the lips. The skin lesions may appear as erythematous macules, lichenoid lesions, erythematous multiform-like lesions, flaccid bullae and erosions typical of the pemphigus, or tense, more deep-seated bullae. Immunopathology evaluation reveals the IgG and the C3 deposition. in the intracellular spaces of the epidermis and the basement membrane zone. However, immunoprecipitation is the definitive test, and it shows the autoimmune antibody against 4 high molecular weight keratinocyte proteins. So the treatment for the underlying disease should be initiated, and treatment for the bullous dermatosis with pioprenoson and immunosuppressives should be balanced with the treatment of the tumor.
Yeah, this condition, the one that you should have talked about too, somebody talked about this, you guys should write it down because you'll see this. You're probably not going to see Pemphiogoid vulgaris much, but what you will see is chronic benign familial pemphigus, and I'm going to put a couple of slides on that for you. Now, let me talk a little bit about this. This is a condition that is usually seen in patients in their midlife, like 50s, 60s, etc. Hold on.
What's the name of it?
It's also known as Haley disease. Chronic benign familial pemphigus. Chronic benign familial pemphigus. Or Haley disease. It usually occurs in the armpits, groin. Here's the groin lesion. You see that? It looks like an intertrigo of sorts, but you can see the chronicity of it. You see all this is kind of weird looking, and you see these erosions there? These are the people, by the way, that are treated with dapsone. Prednisone and dapsone, or just dapsone. Now, look, this here is in the anal area between the butt. See that? This is a condition you're going to see. Here's the lips of the vagina. You can see it. It's mostly in the intertriginous area, but it does occur on the body, and that's why I want you to see this. This is part of chronic benign familial pemphigus, which is on the back. Listen, I want to just correct myself because it just came to me. The cicatricial it's called cicatricial pemphigoid, not pemphigus. The one that involves the oral mucosa or the eyes. Okay, so it's cicatricial pemphigoid, and if you see someone who comes in complaining of sores in the mouth, they usually occur on the inner lips, sometimes the gums, but usually the inner lips, and it's known as cicatricial pemphigoid. Can you put that on the list, Becky? So these are examples of chronic benign familial pemphigus. Now see this, if you see something like that, don't think they have a ringworm, okay? If you think of ringworm or nodular eczema, it's just too large. And I think the patients complain of some pain in it because of the amount of erosions that you see there. These are some post-inflammatory changes as part of herpes gestationis. There's a form of pemphigus that occurs in pregnant women. It's called herpes gestationis. It's nothing that looks like herpes at all. And it's a real misnomer. It's a form of pemphigus that occurs while someone is pregnant. Frankly, I don't remember if it happens in the third trimester or before that, but you treat it very much like pemphigus. And I'll do a little more reading. Can you put on my list herpes gestationis and disease of pregnancies, please? And what you do is you see the same thing. Blistering, bullae, these are post-inflammatory areas. And Becky, just look that up for next meeting so we could do a more complete list of the pemphigus. Just, again, just go over chronic benign familial pemphigus, because we do see that. We don't see a lot of pemphigus, herpes gestationis pregnancy, so you don't have to spend too much time. I just want you to know that it does exist. And these are some pictures of pemphigus foliaceus. See, this picture comes in, looks like they've got erythroderma. They're red all over their body, right? But if you do your biopsies, you're going to find out that they have acantholyses. And this is what they look like. These are pictures of pemphigus foliaceus. It looks a lot like eczema almost, right? But it's not. It's just a superficial form of pemphigus. See on the scalp, on the body. Again, see, just have to make sure I have the right slides here, the right slides. That was pemphigus. They called that pemphigus seborrheic, but biopsy will distinguish acantholysis from other causes. Okay. Now, NLD, have anybody in the practice seen it? Necrobiosis? Yeah? This is what it looks like. It can occur anywhere in the body, but the most common area is the shins. You see this? You can almost see the fat through it. You see how it's a little bit yellow here? It's as if the skin is see-through. And this is what it almost always looks like. You see that? It looks very trophic. And you see the fat here, you see the vessels here. And just like it implies, it's necrobiosis, lipoid necrobiosis. That means something's necrotic there. Okay? And it's usually inflammation deep in the dermis and superficial fat. I bet you'll tell us about it now. But this is what it looks like. It's usually in the shins. Usually. I'll tell you a little bit more about it after she talks to us about it. Okay? You want me to read it? Okay.
Alright, so the necrobiosis lipoidica type form. Age of onset is average 20 to 34 years in insulin-dependent diabetes patients and an average age of 49 years in non-insulin dependent. The ratio of female to male is 3:1 in both diabetic and non-diabetic patients. 60% of patients with necrobiosis lipoidica have diabetes mellitus. 20% will have the glucose intolerance or family history of diabetes. Clinical manifestations. Lesions usually begin as the brownish red or skin-colored papule that slowly evolves into a well-demarcated waxy plaque of variable size. So the sharply defined and slightly elevated borders retains a brownish red color to it, and the center becomes depressed and acquires a yellowish orange hue to it. Now, throughout the lesion, the shiny and atrophic epidermis and multiple telangiectasis of variable size is seen.
And you see these are the telangiectasias that she's referring to, because anytime there's atrophy of the dermis, okay, it's like you're looking through a glass and you see the blood vessels. That's what she means. And it looks like these little vessels here, as you can see, here and here.
Ulceration may occur within the plaques and healed ulcers result in depressed scars. Burnt-out lesions appear as tan areas with telangiectasia. Distribution, its most common location for 1 to 3 lesions is in greater than 80% occurs on the shin. At times it could be symmetric. less commonly on the feet, arms, trunk, palms, soles, face, or scalp. Diagnosis is lesions are so distinctive that biopsy confirmation is not necessary. However, biopsy may be required in early stages of the disease tubular granuloma annulare, which is one of the differentials. Treatment is topical potent steroids with occlusive dressing have proven to be beneficial, or even intralesional triamcinolone in the doses of like 5 mg per milliliter into the active lesions or lesions margins usually arrest the extension of the plaques of necrobiosis lipoidica. The best treatment would be with the TMC suspension. And the last alternative would be excision of the entire lesion with grafting, may be required for ulcerations.
The major thing that you need to know with this is the less you do, the better off you are. This is one of these things where if someone comes in and says to you, here's what I have, and you say to them, do you have diabetes? And they say, oh my gosh, why are you asking me that question? And you say to them, because 60% of the patients have diabetes and 20% have an abnormal glucose tolerance test, if they have this condition and don't have diabetes, they're more likely to develop diabetes. So it's kind of a precedent to tell them, listen, just keep close eye on your blood sugar because this may antedate your diabetes.
Does this have anything to do with venous insufficiency or arterial insufficiency?
Well, what happens is that there's two things that happen in this condition. One is that there's inflammation, chronic inflammation in the lowest part of the dermis where it attaches to the fat, where the two come together. But what they found out is that the circulation is compromised in that area too. In other words, you know, one of the problems with diabetes is that you get premature atherosclerosis from the entire fat metabolism, glucose metabolism, and look what a cute picture. And basically what happens is that, that's Rembrandt's house, by the way, the famous artist. What happens is that the vessels are occluded, so people used to put these patients on, what's the name of that drug that's 1 gram? Trento and, you know, like blood thinners, trying to get the blood through that, but that doesn't really help. What I would suggest you do is, if you want to shoot them once with intralesional steroids and give them some topical steroids for just a little bit, you can do that. But if you continuously put on strong steroids, you might enhance the skin breaking down because the skin is already thin to start with, and then they'll develop an ulcer. And once you develop an ulcer, if you do too much, you're going to have a whole hell of a lot of issues to deal with it because they basically don't granulate them well because they've got no blood supply there. So then that's why it says here, excision or grafting may be required for the ulceration. So I always say the less you do, the better off you are. And it's one of those sad cases where a lot of these beautiful girls come in with these things, and there's not a hell of a lot that you can do to help them. And if they say he's going to get bigger, tell them it's unpredictable. But tell them you'll be there to help them try to prevent that. You know, so you can use steroid, you know, creams or intralesional, but you got to watch them and don't do it too much, you know, because then it'll break down.
Any uniboot or compression therapy?
No, there's not much that's really helpful. You know, that's one of the problems. Okay. Now, basically, this is a good topic. You've got all good topics there, because we see this Morphea. How many more topics do you have?
No, that's the last one.
Okay. Hold on, let me go to my Morphea pictures.
have the microphone?
The major differential diagnosis you're going to have to do here is distinguishing this process from lichen sclerosis atrophicus. Now, once you get good at it, it'll be easy to tell the difference. But they both have they're atrophic in nature, okay? Whereas lichen sclerosis atrophicus can give you squamous cell carcinomas. It doesn't occur too often. The Morpheas do not, you know? But one thing you do need to test for, and I don't know if it's in your notes, is Lyme's disease. Is that in your notes? Becky?
No.
Okay. So,
Just a little.
SCL70 is an antibody that you test for systemic progressive sclerosis or scleroderma. You just have to make sure that this form is a localized form of scleroderma. That's how it's usually known as. The localized form of scleroderma doesn't affect your internal organs, just your skin. Like this called lupus erythematosus, like that. So, you know, you think of discoid as compared to systemic. In Morphea, you think Morphea versus scleroderma because it's known as limited scleroderma. This is what it looks like. It's the epidermis is somewhat atrophic, and at the same time it forms like a scale. But the underlying dermis is extremely thick and it forms either hypopigmented plaques or hyperpigmented plaques, and sometimes around the edges here, the plaques will get erythematous. So these, see this patch? This is a patch. People come in looking like this. These are patches, I think it's this big one here. See, it goes all the way down here. Another patch.
What's the name of the test again?
It's called SCL-70, which is something that we see in scleroderma. And it can affect any part of the body. This is the scalp. You see this is a atrophy of that area with no hair. Here's another area of the scalp with no hair. See this kind of pinkish. Once you learn a little derm, once you see them, you won't forget it. It's easy. You just got to see the first one. Here's another one here. There's also something called linear morphea. They call it coup de sabre. It comes in this, right in the forehead. Runs like a line in the forehead. But you probably won't see these. This one is on the face, which is pretty rare. This is on the leg, that's rare. Most of the ones I've seen, if not all, were in the trunk like this. You see this white patch? So you got to differentiate morphea, localized morphea from lichen simplex, lichen, what did I just say? Lichen sclerosis atrophicus. And this is a patch right there. You see that? Same patch. That's NLD. No? Yeah. Yeah, I got that in there. Okay, now Becky will tell you a little bit about this and then we'll clean up.
Morphea is a localized and circumscribed cutaneous sclerosis characterized by early whitish, later ivory-colored hardened skin. Epidemiology, rare between the ages of 20 and 50 in mania morphea. Earlier, pansclerotic morphea, a disabling disorder, usually starts before age 14. Females are affected about 3 times as often as males, including children. Etiology is unknown, at least in some patients, predominantly in Europe, with classic morphea, have sclerosis due to Borrelia periphery infection and is not too sclerotic, the lesions can disappear with prolonged course of antibiotics. Pigmentation, however,
Not
may
great
persist.
stuff. Borrelia is what causes Lyme's disease. That's why you gotta get a Lyme spider, just to make sure that you're not dealing with Lyme's disease. And that's one of the lab tests, and then the other one is the SLC-70, which SLC stands for scleroderma.
SCL, is it right?
Yeah, I mean SCL, SCL-70. SCL stands for scleroderma-70. It's an antibody.
Morphea has been noted after.
It's called Morphea.
Morphea, sorry. Morphea has
And
been.
I think it's misspelled here, but I'm not sure. How do you spell Morphea?
MORPHA.
EA, I think. Is that EA? Yeah, you just spelled it different. So we'll correct that. See, it even happens to the best. Okay.
PHEA.
Yeah, it's Morphea.
So it has been also noted with breast cancer patients who are treated with radiation. It's not related to systemic scleroderma. We just spoke about the lab test that we're going to do for that. Classification, there are several kinds. Circumscribed, macular, linear scleroderma, frontoparietal, generalized morphea, pansclerotic, which usually involves the dermis, fat, fascia, muscle, and the bone.
You spelled it right here.
Yeah.
Okay, good.
Clinical manifestation, the plaques are circumscribed, indurated, hard but poorly defined areas of skin, 2 to 15 centimeters in diameter, round or oval, and often better felt than seen. Initially are purplish or Maui color. In time, surface becomes smooth and shiny. After months or years, becomes ivory with lilac colored edge, like a lilac ring. May have hyper and hypopigmentation in involved sclerotic areas. And rarely lesions become atrophic and hyperpigmented without going through a sclerotic stage. And then I have a few pictures down there.
This is the very active area because it shows some erythema and some, you can see it's purple almost. The next one shows a more advanced form where you get the post-inflammatory hyperpigmentation. And then you can see this is pretty bad. I don't know, it looks like very white, bad looking plaques. Okay.
Distribution, again, different kinds of different areas. So circumscribed is trunks, limbs, face, genitalia, less commonly eczema and the perineum. Generalized initially on the trunk and the thighs. Linear usually on extremities or frontoparietal scalp and face. Here it may resemble a scar from a strike with a severe, and has it's called en-coupe des sabres. Macular, small macular patches, confluent clinically indistinguishable from lichen sclerosis atrophicus. Atrophic is atroderma of Piscini and Perini. I don't know what that means, but it was in the book.
We haven't talked about atrophodermis. We'll talk about it some other time.
Pansclerotic is on the trunk or the extremities. General examination. Morphea around the joints and the linear morphea may lead to flexion contractures. The pansclerotic morphea is associated with atrophy and fibrosis of the muscle. So extensive involvement of the trunk may result in restriction of restricted respiration. With linear morphea of the head, there may be associated atrophy of the ocular structures and atrophy of the bone. So morphea can be associated to lichen sclerosis atrophicus. Diagnosis is usually confirmed with biopsy. Blood test basically done to rule out the Lyme's infection. And management, there is no effective treatment for Morphea. However, Morphea, like lesions associated with the Lyme's, treatment with parenteral penicillin or ceftriaxone for several months. Better results if combined with oral glucocorticosteroids. And then phototherapy. It's not easy or very successful because of the prolonged radiation times and disfiguring hyperpigmentation of the irradiated areas.
Well, this is another condition where the treatment is very poor. There's not much you can do to prevent it and not much you can do to treat it once you find out it's not associated with any underlying disease. So today you got, without having to know too much about treatments of two conditions, because they don't work, you know? And that's, they say about dermatology, you know, if it's wet, dry, and if it's dry, wet it, that's not right. But they say too, that there's a lot of things you can't do, but that's wrong. But these are two conditions that do not yield well to treatment. Okay. Now, that ends today's session. When are we, I mean, what's 2 weeks from now?